All right. Hi, everybody. Thank you all for being here today and for listening during the sessions and for coming into the live chat. I think we're going to start by talking a little bit about some of the questions that came up in the last 5 or so minutes. And then we're happy to answer any questions that you have kind of on the spot. So I think you're able to put those into the chat here just by using the chat function on Zoom. And we're happy to take any questions that you have. And of course, happy to answer other questions through the conference platform if you have them either now or after the fact. So I'll start with some of the questions that I didn't get a chance to answer in the metastatic session. There's a really interesting case scenario that was posed. A patient with biopsy-proven bone metastases and mediastinal adenopathy who started single-dose fulvestrant at the original dose of 250 milligrams monthly in September 2002, 19 years ago, the author wrote, which I assume was to make sure we knew it wasn't a typo, which is incredible, after progressing on exemestane after a brief 9 months. She now has increasing CA2729 and hip pain. Bone scan is this week. I suspect she's progressing. Would it be reasonable to return to an AI with a CDK4/6 inhibitor since it's going to be 20 years since she saw an AI? Or would it make more sense to use abemaciclib single agent? And this is a really interesting question, and one of those questions where there's probably not one right answer. I would be interested to see what her bone scan shows, and if that hip is causing her pain, I would probably consider radiation just to palliate that pain while you think about your next options. I don't think it would be wrong to return to an AI with a CDK4/6 inhibitor. I don't think you're probably not going to cause that much more in the way of toxicity with the CDK4/6 inhibitor plus an AI as you would by just giving CDK4/6. But this is someone with such an interesting course that I might also think about doing Guardant or foundation liquid like blood-based testing just to understand, are there any mutations that you can identify that might be causing her to progress after such a long period of sort of quiescent disease. And I guess there's also the question in someone like this of, would you go up to a higher dose of fulvestrant to see if you could kind of regain disease control? So probably one of the situations where you have to talk to the patient and kind of have a shared decision-making discussion about all these different options, try something, see how it goes, and then, kind of alter the course as you need to. But it seems like this is someone for whom their breast cancer has definitely become a chronic disease, a nice thing to see in the metastatic setting. Dr. Ma, I don't know if you have other thoughts on that or anything else you want to share on that case. Very interesting.
Sure. Yeah, I agree completely with what you said. I think I would be very interested to, test the circulating tumor DNA to look for some, mutation that may actually thinking about you might change your route. For example, if the patient had a ESR1 mutation, potentially it would be good to enroll on the newer third selective estrogen receptor downregulator trials. I think, yes, but I think, going on an AI plus CDK4/6 inhibitors in this setting is probably appropriate.
Yeah. The other thing I was thinking with this patient, I don't know if she's had germline BRCA testing, but if someone was diagnosed with breast cancer 19 years ago and is still doing well, presumably they could be young and maybe at risk for a mutation in BRCA1 or BRCA2. So if they haven't had genetic testing, maybe considering that as well. And potentially this could be a PARP inhibitor candidate or someone for whom if they had like a PALB2 mutation could go on a PARP inhibitor trial. So probably lots of options for this lady.
Yes, I agree.
Yeah. Another question that was asked was in the HER2 positive breast cancer study we talked about in the talk, looking at patients who are ER positive and HER2 positive and looking at endocrine therapy plus trastuzumab versus chemotherapy plus trastuzumab. The questioner points out that in the hormone receptor positive patients who are HER2 positive, there was more benefit seen in those who were ER or PR positive as opposed to those who were positive for both hormone receptors. They said it's contrary to our expectations. Any explainable reason? What's that? Sorry? Oh, sorry. I thought someone was saying something maybe technical. But anyway, I think that's a great question. And going back, to that slide and sort of thinking more about that patient population, what we see there is that in those subgroups, it's a pretty small subgroup that's either ER or PR positive, 37 or 39 patients in each group. And then patients who are ER and PR positive was a larger proportion of patients. So I don't think it's necessarily anything in terms of disease biology, because I agree, if anything, you would think that patients who are more hormone receptor positive are going to gain more benefit from having, endocrine therapy added to their trastuzumab. And if anything, that's probably why we see the disease-free interval that's longer being more conducive to benefit from endocrine therapy. But I think that probably the main reason we are seeing that is that it's maybe coincidence with a tiny sample size of ER or PR positive patients. And that probably if this were a larger study with more patients in that group, those two would even out a little bit more. I mean, I can't say that for certain because, no one has a crystal ball, but that's sort of my thought. Dr. Ma, I don't know if you have any other thoughts on that particular question.
No, I agree with you. I'm curious. So in your practice, if you have a patient with bone-only mostly disease, estrogen receptor positive, HER2 positive, what's your strategy? Do you give, THP first, then followed by adding, kind of switching to HP maintenance and, endocrine therapy, or do you go with just all targeted and endocrine therapy first?
I think it's such an interesting question, and definitely one where this particular trial, I feel like, gives you a little more leeway to shy away from the taxane. And I think, so much better for patients, because the hard thing about taxane-based chemotherapy is, you got to lose your hair, there's neuropathy, and you feel like a patient again, whereas if you can be on, HP or just H, and endocrine therapy, it's much more conducive to good quality of life. So I think, it probably depends on the patient. If I had a bone-only patient, particularly one who had either was presenting with de novo disease or who had recurred a far amount of time out, I think it would be very reasonable to just do HP plus endocrine therapy. And I have, in fact, done that in several patients, particularly those who are older, or those who had residual neuropathy from their taxanes. And I think trials like this give us leeway to sort of, use the art of medicine a little bit more and talk to patients about the pros and cons.
Yeah, I agree.
Yeah, it is really interesting. I had one patient who came to me actually not that long ago who had ER positive, PR positive, HER2 positive disease. And she wasn't bone only. She was like bone only and node, but was too frail from other medical conditions to do trastuzumab. She had a cardiomyopathy. And so her oncologist had actually recommended hospice. And I instead started her on letrozole alone, thinking like she probably could tolerate that. And she's actually done really, really well now for like 2 years. So it kind of goes to show that there are lots of ways. You don't have to go all in to give the patient some benefit, particularly in the metastatic setting where, you really are treating a chronic disease.
Sounds good. I think there are more questions.
Yeah, I see this.
Disease.
Are there any trials of standard dose chemo versus side effect adjusted dosing for metastatic breast cancer? Not that I know of, and I don't know if you know of any. I think it's hard to do prospective trials like that just because it's difficult to determine what your endpoints would be, and side effects are so subjective. But I think, the study that the patient advocacy group looked at here, just showing how important it is to think about dosing and about side effects as you're treating metastatic patients, kind of brings to bear the fact that that's such an important topic to discuss on trial or off trial, particularly for patients you're treating off of study where you have more leeway to adjust doses for side effects.
Yes.
Okay.
I'm not aware any first-line trials with sacituzumab govitecan. I know that there's effort to bring these agents like in the minimal residual disease setting, like neoadjuvant chemo if they're residual disease, but that's still kind of ongoing with the study protocols.
Yeah, no, I think these studies are rapidly being developed. And I imagine, like with anything that is successful in the metastatic space, like, trastuzumab is a good example of that. And we have lots of examples. Sacituzumab, which seems to be so beneficial, probably will start to make its way, earlier on into the metastatic treatment paradigm, and, potentially even could have a role either for salvage or even an upfront treatment of disease. So I think if I were going to predict, I would predict we would hear a lot more about this drug in the years to come. It's very exciting. Let's see. What situations would you use everolimus? Tough question. Interesting question. I use it actually not infrequently, particularly in patients who are estrogen positive, metastatic, have progressed on CDK4/6 inhibitor based therapy, and seem to still have endocrine sensitive disease, but don't have other trial options and don't have a PIK3CA mutation. I use it in combination with fulvestrant, in combination with tamoxifen, and also in combination with AI. So I've used it in lots of different settings in that way. I think, one thing to keep in mind with I've had actually pretty good tolerance of this drug in my practice overall, I would say. But speaking to the side effect issues, I think some patients do better when you start on like 5 milligrams or 7.5 milligrams and then titrate up. I always use the dexamethasone mouth rinse because I think that helps a lot with the oral toxicity. And then it's a drug that I've also used in situations where alpelisib has not been well tolerated in my PIK3CA mutant patients, where I've wanted to bring in something kind of along that path. So that's probably the summary of how I would use this drug. What would you say, Dr. Ma? Any other thoughts on everolimus?
No, I agree with you. I usually start with CDK4/6 inhibitors, and if they don't have PIK3CA mutation, that's when I would, think about everolimus. And I agree with you with the mouthwash, dexamethasones. These really are very helpful.
Yeah, no, it definitely makes it a bunch more tolerable.
There's a case.
Yes, looks like an update on that long-term patient with the fulvestrant. She's currently 84, never BRCA tested or PIK3CA tested, so we're going to get liquid biopsy done potentially. She was diagnosed with CLL in 2009, so you're right, probably not a clinical trial candidate, but great that you've been able to ignore that disease and just watch it for now, and seeing what the liquid biopsy shows, and then potentially you could do something targeted off study if you've got something. But certainly going back to the original question, the AI CDK4/6 option is definitely there. Here's a really nice topic in the earlier stage patients. And Dr. Ma, maybe you want to take this one first. Can you comment on when you would use Xeloda versus olaparib in the adjuvant setting for BRCA mutated patients?
Yes, I think that's a very important question. And, there's no answer that can have evidence backup yet. We don't have any data that compares Xeloda versus olaparib in the early stage setting. But we have Olympiad in the metastatic setting. When you compare olaparib with chemotherapy of physician's choice, which included Xeloda, that olaparib had better progression-free survival. So, that suggests that olaparib would be a better drug for BRCA mutated patient population. And also, if you look at the Untitled trial, the neoadjuvant PARP inhibitor single agent has a very impressive PCR rate. So I think that all, I would say based on those data, I would use olaparib. I think it would be difficult to sequence, like, for example, you give a year of olaparib, and then would you still do Xeloda? I don't think I would do that.
Yeah, no, I agree with you 100%. I think, Xeloda is a great option, for patients, but we know that, even despite Xeloda, a number of patients who are triple negative will recur. And in the olaparib data, it seems much more favorable. And it may be that BRCA positive patients may have more favorable responses to chemo anyway, and may do better regardless. But I think I would probably choose olaparib over Xeloda for most patients who I have the option to do that in. I do think, one thing that's interesting about this trial is that patients had to have pretty significant amount of disease, either, significant amount of disease if they were treated with chemotherapy adjuvantly, and a decent amount of residual disease if they were treated in the neoadjuvant setting with chemo. So I think there are still patients who would be Xeloda candidates who are not yet olaparib candidates, just because of the inclusion criteria for this trial. But I think this olaparib data is some of the most exciting stuff we've seen in a long time. It's really fantastic.
Yes, and I'm curious what your thought is, because when you look at the eligibility criteria, if you have ER positive breast cancer, you have to have so many positive lymph nodes. And I think that, so for example, if you have a patient with only, one positive lymph nodes, and, would you still give her the PARP inhibitor?
I know, it's really tough. I actually have been thinking about this since ASCO, because I've had a couple of patients who, who are BRCA positive, who've just finished their upfront treatment. And one of whom is a candidate for the olaparib, but one of whom is actually not, because of just not having enough bulky disease. And I think that it'll be interesting to see what, as we sort of hone in on for whom this drug will be approved by insurance or not in the adjuvant setting, whether there's any leeway that we're given. Like with some drugs, there's been leeway given to providers in some ways to decide what they want to do somewhat outside of the confines of the trial. Like when the tucatinib-based regimen was approved for metastatic HER2 positive disease, it was approved as second line or third line, even though it was only studied in the third line setting. I wonder what this will look like for olaparib, because there are patients definitely in whom you would be tempted to use it who didn't quite meet the criteria for the study, because it was well tolerated and appears to be quite safe, and certainly seems to be improving outcomes for these women.
Okay, there's a question about, are there any new agents with, I think is it CDK6 rather than CDK4/6 predominant action to minimize toxicities? I'm not aware of any specific CDK6 inhibitor. Do you know, Jane?
No, I'm not aware of any.
Yeah.
So maybe more to come on that. Who knows?
Yeah. Any evidence of HRR mutation in breast cancer? I'm not sure I understand that question.
I wonder if there's, maybe whoever types that question, if you want to type it again, I'm not sure if they meant HRD mutations or HER mutations. but maybe just to clarify that question a little bit further for us, and we can get back to it.
Okay, the next one is yours. Have patients, you know,
Yes, case question. Someone has a patient just started on Piqray and developed a severe rash within 10 days. Have you had good luck re-challenging at dose reduction? Can't use steroids as blood sugar has already shot up. That's a tough one. I mean, I will say my honest experience with Piqray has been that it is very hard for many patients to tolerate. I tend to start people at a lower dose than studied and increase only very gradually. I've had one patient who developed a severe rash on Piqray actually, and she was one of the women who I ended up transitioning to everolimus instead with her fulvestrant. And this was after progression on a CDK4/6 inhibitor plus AI. So I have not had, we did actually try to re-challenge her. She developed the rash again and it didn't work out. So not to say you shouldn't try, but you may want to have a backup plan would be my honest opinion.
Yeah, one thing is just to make sure that the patient was also on like prophylactic antihistamines, because that really reduces the incidence of higher grade rash. This is challenging.
That's a great point.
Mm-hmm.
I think we've got a neoadjuvant question there if you want to tackle
that. How do you approach additional carboplatin in neoadjuvant treatment triple negative breast cancer? Do you routinely add it for all triple negative breast cancer to the dose dense ACT? Does BRCA status change your decision? Yeah, okay. So I do not routinely add platinum in the neoadjuvant setting for triple negative breast cancer. I may add it if the tumor size is kind of T3, for example, and multiple positive lymph nodes, because it does increase the PCR rate, and I think, and that's important for our patients. Does BRCA status change our decision? So, you know, BRCA mutated tumor tend to be more chemosensitive. I don't think necessarily you have to use platinum drugs. So I don't think that would change my practice.
Yeah, no, I agree with what you're saying. I think, you know, the approach to this definitely differs widely. And I think it is very patient, you know, sort of like individual patient dependent. You know, for me, the decision usually comes down to how well do they tolerate dose dense AC, because I usually give the dose dense AC first, and how well do they respond, you know, and also how bulky was their disease to begin with. When I do use the carboplatin, I use it weekly as opposed to every 3 weeks, because I find it's much better tolerated that way, both in terms of side effects and in terms of blood counts. And you know, there are patients for whom I've started it where I've ultimately had to pull back on the carboplatin. You know, they get 8 of 12 weeks with carboplatin or something like that, just because of fatigue and nausea and cytopenias. But you know, I really use it. I use it in BRCA positive as well as non-BRCA positive patients, but mostly in patients who've tolerated AC well, whose bone marrow seems to be, you know, able to tolerate that, and for whom maybe they haven't had as robust of a response to the AC as I would want.
Yeah, I mean, in our center, we still have a trial with taxotere plus carboplatin for 6 cycles. It's like a TCH without the H. So that has shown to have a, you know, fairly high PCR rate, about 50%. You know, so it's a regimen that actually we're trying to get rid of anthracycline.
Yeah, that's what a great concept, right? Yeah.
Okay. So they're referring to HRD mutation. I'm not sure the context of that question. I think, yeah,
probably that was the question where they said, is there any evidence for HRR mutations in breast cancer? And maybe they're saying it wasn't HRR, it was HRD. So probably like homologous recombination deficiency.
Sure. Yeah, I think in the metastatic setting, there was a TBCRC trial that evaluated olaparib in patients with somatic BRCA mutation or germline, you know, other HRD or, you know, genes that are mutated. So the PALB2 mutation, you know, germline mutation carriers also benefit from it. And then somatic BRCA mutation, mutated breast cancers also benefited from olaparib. Actually, their response rate was fairly similar to those with germline BRCA mutations. But in the early stage setting, I think we don't have any data to use olaparib in these additional setting yet. I think it is attempting though, but hopefully there will be more trials in that space.
Completely agree. Yeah.
Yeah. Okay. I think, do we have anything else?
I think we're actually probably running close to time looking at this.
Yeah. Really, thank you very much for your time.